like I said, this is a surgery where blood loss is the most important thing that we have to monitor. And the best way to treat it is to prevent it, or if you cannot prevent it, anticipate it. Prevention is not going to be helpful because it's just a surgical bleeding. It's not for lack of any coagulation factors or any. But on the other hand, there was some consideration into preloading these patients, increasing their volumes, diluting their hemoglobin, so that the actual blood they're losing has a less amount of hemoglobin lost. And at the end of the day, they will pass some of the crystalloids by urine output, and by the end of the day, they will have a more concentrated, less anemic blood left in their vascular system. But not everybody follows that trend. I don't tend to preload them with fluids beforehand. Like I said, part of the management as part of the anesthesia team is to create a certain type of safe hypotension to decrease blood loss, or at least avoid hypertension or a higher blood pressure. The other way to do it is by strictly monitoring the amount of blood loss. By that I mean it should be, you have to be as precise as possible in terms of how much they're losing. As you know, it's easy to lose track of how much blood they're losing. They might have a suction that's connected to a cell saver. They might have another suction that's connected to another the container. They may have a lot of 4x4s and towels and stuff. So it's difficult to gauge exactly how it is, but by assuming that one 4x4, a wet one 4x4 will have so much blood, a wet towel will have so much, monitoring what's in the cell saver, monitoring what's in here, monitoring how much of irrigation they're using to have a more precise estimate of the blood loss. That's probably the most important work of monitoring blood loss.
Do you have a set hemoglobin that you use as a gauge for transfusion?
No, that's, obviously if it's below 7 or so, you might think, especially at what stage of the procedure. The spine surgeries basically have two or three different phases, but there was from the time they make incision all the way until they dissect, expose all the spinal processes and the vertebral processes, that will be a blood losing phase. And once they expose and they're starting to put the instruments, that part of the procedure does not have a blood loss. So if you have a patient's hemoglobin getting to 7 when they're dissecting through the vertebral bodies or the vertebral part of the surgery, you can anticipate blood loss more than what you have already. So you may want to intervene early. But again, your number should not be the only one which guides you into determining whether you need blood transfusion or not. It's the clinical picture of whether there is tachycardia, whether there is hypotension, whether there is signs of ischemia in different parts, whether that includes decreasing urine output, and all that to gauge you to make a decision whether blood transfusion is time, or you may want to wait a little longer, or you're going to do it at all. We have done surgeries, spine surgeries on a 50-kilo child losing maybe 150, 200 ml of blood. So, and then we have other patients, especially the ones that are not idiopathic scoliosis, that lose significant amount of blood. So it all depends on what the clinical picture is, what the context is in which this blood is lost.
Thank you.
Yeah.